Good afternoon, everybody. If you're on the East Coast, I guess it's afternoon. Central time, you're just kind of cracking into that. So I'm going to give everyone maybe another minute or two just to see if a few other people will join, and then we'll go ahead and get started. All right. Well, I think we're going to go ahead and get started. Looks like even though the ticker continues to add folks periodically, I know we only have 30 minutes, so I want to allow for a little time for questions or things like that at the end. So, Nick, do you want to go ahead and start the recording so we can post that in the chat afterwards?
Yes, it should actually. Let's see. It should actually already be recording. Since we're in a webinar, it should be auto recording.
Perfect. All right. Well, welcome everyone. For those of you that it's their first webinar, and my name is Scott Eiselt. I serve as the VP of Clinical Operations for IMC. I'm also a physical therapist by trade and been a PT for just over 20 years at this point. So for those of you who aren't unfamiliar with IMC, it stands for Integrated Musculoskeletal Care. Many of you are probably here because it's a benefit offering through your employer. And so if you're unaware of kind of what we do, we're a musculoskeletal healthcare company. So we provide what we'd call movement-based care to assess and better understand kind of the root cause of somebody's issue, whether that be neck pain, back pain, joint pain, muscle or tendon issues, you name it. We can assess that and then identify if you're a good candidate for the care that we can deliver, or if you would be better served for a different discipline. All right. And so today, in this webinar, we're going to actually be talking about musculoskeletal presentations and care, but mainly those things that are maybe myths might be strong, but myths or misconceptions, things that are poorly understood or have been taken kind of out of context or changed over the years, or maybe the society has focused on it in a way that isn't meaningful or accurate to how we should understand it. So we're going to tackle those things. I'm going to try to go through as detailed as I can. Each one of the kind of main topics could probably be a topic among itself for 30 minutes, but I'll try to kind of hit some high points and then leave a few minutes at the end for some questions. All right. So I think we're all familiar with all the various sources of information. We probably have too many sources at this point. With Google, people affectionately call it Dr. Google or WebMD, or people would even go on YouTube and try to find different exercises or things that they can do. And there's a wealth of information out on the internet. And at times this is wonderful. It can start to give us a better understanding of kind of what we might be dealing with and things like that. But I also think it needs to be taken with a grain of salt, in that we might type in what we think we have, yet we haven't been evaluated by a medical professional. And then that can lead us down a treatment pathway that may or may not be right for our condition. All right. And so I think just kind of word of caution, if you will, or public service announcement, is just be careful what you read. Obviously, we all know that what's on the internet isn't all necessarily true. So be aware of your source. But also be aware that your problem, although it might present one way, what you think it might be, the source of it might be something different. So be careful to apply treatment if you're not getting better based on a recommendation that someone hasn't evaluated you, or they're taking more of a what I would call a cookie cutter approach towards your problem. All right. I think you're going to see even more of this. My guess would be, especially with the advent of our AI technologies and things like that, where where we have to kind of look with some scrutiny at what we're reading and what's being put online. Okay, so I think it's good to gain information, but I put this out there, just be careful. But it's also kind of what prompted some of these topics. If we have questions about different musculoskeletal presentations, hearing from a professional and kind of getting different opinions is good. It's healthy. So the first thing would be I want to touch on is different activities and exercises. What's healthy? What's not? How are we impacted by those things? And just kind of throw some fast facts or truths out there. Maybe spell a couple of myths or mistruths, and then dive into some other things. So first one, I'll just kind of go down the list. First one would be stretching. There's a lot of stretching. We should stretch. We have to stretch before we do activity. If I don't, I'm going to get injured, or stretching helps prevent injury, or, so what is out there? Well, there actually hasn't been any evidence that directly links stretching to injury prevention. All right. Now, before we all kind of, that doesn't mean you shouldn't do it. It's just make sure you know what you're doing it for. Okay. So there's two different types of stretching. There's what's called static stretching, and that's what we all probably know or are familiar with. This is when you put, a muscle or soft tissue, if you will, muscle, ligament, tendon on stretch or elongate it, and you can feel it pull, and you hold it there for a given amount of time. All right, you're not really moving. That's what's called static. All right, it's in place. That is a type of stretching that is best used for improving and or maintaining flexibility of that structure. Okay, really good to do when you're warmed up or after exercise. All right, to help kind of reset the length of the structure. Static stretching like that, though, has been shown to actually reduce performance prior to some type of athletic activity. All right, so it's not recommended that you do static stretching prior to, let's say, a jog or a bike ride, or lifting weights or that kind of thing, because it can actually reduce the performance. All right. Instead, dynamic stretching is kind of a better way to warm up, so you don't surprise your tissues, with an activity. So dynamic stretching might be, kind of more movement-based. Kind of, you could do like, kind of hip swings or arm swings, or kind of light activity to kind of get your tissues used to working. Okay, so that's kind of the what's out there on stretching. Hopefully that helps for those that feel like, oh, I go out and I run and I don't stretch beforehand, and that's okay. That's okay. All right, and everyone's a little different. All right, so you're not necessarily setting yourself up for injury. Next thing would be bone health. Okay, there's this people, you hear about osteopenia or osteoporosis as we age, and these are conditions that our bones can actually become brittle or softened, as we get older. Right? It's hard for our body to maintain healthy structure. Well, sometimes we're a little careful, and so we're like, well, I don't think I should jump or run or do things that are hard on my bones, especially as I get older. But actually, the contrary, you should keep doing those things. Okay, so weight-bearing exercise, lifting weights, walking, jogging, those types of activities that are actually what's going to stimulate your body to maintain the health of the bone. Okay, I'm not implicating, let's say aqua aerobics or water aerobics or water. Sometimes that's necessary for people because it's too hard to do weight-bearing exercise, but you shouldn't make that your sole purpose or your sole kind of mode of exercise, if you will. And that can actually, since it's not weight-bearing, not a lot of stress on the bones, it is not going to help maintain or even strengthen your bones. Okay, so bones can actually be strengthened. All right, so weight-bearing type of exercise, very important. Next one is arthritis. And, if you we're going to have a little section on imaging here in a little bit, but arthritis is similar to, we call it like gray hair or wrinkling in our skin. Is that our joints do change the way they look as we age. Okay, and contrary to what commercials lead you to believe, arthritis is not always painful. Okay, so it can be present in a joint because the joint's been used or it's been on the planet for a certain amount of time, but it doesn't have to hurt. Okay, so and then inversely, not all pain just because we're older is due to arthritic changes. All right, or we are bound to have arthritis. So those are important points to make. The other thing is arthritis. We think about like the joints wearing out, but actually, arthritic joints love to move. Okay, they need to exercise. That's how they maintain their health and prevent further deterioration. All right, so sometimes it might be hard to get an arthritic joint going, but it actually is helpful once it gets going. Right? There's always motion is lotion, and an object that is put in motion stays in motion. All those things. Okay, so and they've actually looked at studies of active individuals, especially runners, and then sedentary individuals. Okay, and sedentary individuals actually have a higher incidence of arthritic changes in their joints than an active person. All right, so it kind of dispels that idea that we wear out our joints. In reality, we don't. Okay, you're going to rust up before you wear out. I just put this one there. It's kind of funny. Knees over toes. There's actually a guy who wrote a whole book about this. But there's this thought when you squat or lunge or do like leg strengthening, your knees should never go over your toes. All right, you're going to cause knee pain and tendonitis and all these things, and that just flatly isn't true. All right. Now, if someone hasn't been doing deep squats, lunges, things like that, can that be more uncomfortable? Absolutely. There's a lot more pressure on the front of the knee if the knee advances forward further in a deep squat and lunge, but it's not something that needs to be avoided just because we think it's bad. Okay, you can work up to deep squats and deep lunges and step ups and things like that. Okay, and that the more we do activity, the more it gets used to it. So that should be something you progress into. Right. So if you like to do squats and you like to do lunges and you're really diligent about making sure your knee doesn't cross over your nose, you can take a little bit of a breath of a deep exhale. Okay. Another one I've heard, doctors give this advice to patients. You should never lift over your head anymore. All right. That's bad for your shoulders. Well, if you don't ever want to be able to lift over your head, you should absolutely stop doing it. All right. But it is not inherently bad for us. It is something that we're capable of doing and we should do. Right. If we haven't been doing it and we want to start lifting weights, we need to start slow. All right. And we need to sort of gradually build it into a workout routine. But just avoiding lifting things over our head, that's not an appropriate strategy for longevity of, especially of functional activity and things like that. Lastly, running. All right, lots been made about running over probably decades, and I think this is slowly changing. There's probably more runners now and more races every time you look up in every community than there was, a few decades ago. Running does not wear out your joints. All right, there's been a multitude of studies who have demonstrated that running is actually extremely healthy for us. Okay, bone health, I touched that on earlier, but they've found similar studies like I touched about. Is they've looked at arthritic changes in runners, and they have a lower incidence of that. So it's almost like it maintains, all right, the health of our joints and the surface of our joints. It does not wear it out, all right. And even in our lobe, in our spine, right. So those of you who may have heard of degenerative disc, right. So your discs, they start to dehydrate. They get shorter in height, all right. So they have less shock absorption. Well, there's thought that like the pounding of running causes that to occur. And there's been numerous studies that found actually runners retain or keep disc height at a higher rate than non-runners. All right. So there's something about using our bodies that causes our bodies to stimulate either maintenance or improvement of our structures. All right. And I think, don't stop at running where, you have you can replace running with any activity, and our body's really good at stimulating change and the ability to do things if we're consistent with our activity and our stimulus. Okay. All right. Next things, I'm gonna be brief on the injury side. A plug. I think it's next month. 2 months from now, it might be the one after that. But we're gonna do a whole webinar on injuries and the phases of healing and things like that. Okay. But when talking about injuries, there are obviously different types. There are some that might be, if we talk like soft tissue injuries, and then you talk like bony injuries. Well, obviously, at the severity of injury, if you have high levels of pain, 8, 9, 10, or it's a traumatic event, you need to get checked out, and it's important you go see a medical provider in order to do so. All right. But many injuries, our body is very capable of healing itself and returning itself to its prior level of function and ability, if given the ample amount of time, and then sometimes that requires some amount of treatment. Okay. So there's 3 phases of healing. There's what's called the inflammatory phase. That's typically anywhere from a few days up to 2 weeks. Right? And then there's a repair phase. That's the next 4 to 6 weeks. And then there's what's called a remodeling phase. And that's the phase after that repaired tissue is changed back to more normal structure. And that, sometimes happens on its own as we come out of that repair phase. Other times needs to be stimulated with activity. It can take another 6 to 12 weeks, depending on the severity of injury. All right. So that's kind of, like I said, I'm diving into that further in a future webinar. What should we do? Well, if you have a muscle injury or a tendon that's hurting, should we stretch it? All right. Actually, no. Okay. Muscles need to be used. Tendons need to be used. Once they're out of that inflammatory phase, you need to actually work the tendon. All right. They found that stretching is not necessary, nor is it helpful. Okay. So you need to strengthen a tendon. As far as other types of injuries, stretching can often be helpful. So it depends on the type. All right. So what are some other things that people apply? Well, they might put, like, let's say those elastic braces or elastic compression sleeves or things like that. Those have not been found to actually be very, very effective. They are great when it comes to our confidence. So they've been found to be kind of more for our psychological or cognitive awareness. All right. They give people confidence that they have support, but anatomically, they actually don't do anything from the healing or recovery. All right. There are some braces that do, but I'm speaking of those kind of over-the-counter or slip-on braces. They're not highly effective at truly supporting the structures. All right. So, like I said, I won't dive into any further. But if people have questions about different braces or different things like that, we can handle those in the chat if we want afterward. This is an important one I want to spend a little bit of time on, is imaging. All right. And by imaging, I mean X-rays and MRIs. Okay. Taking a look at what our joints look like inside if we have some type of musculoskeletal problem, a pain or an injury. And, if you at all follow sports in this country, it is an athlete gets images very regularly based on really minor injuries. And they do, and there's actually been some articles written about whether that's the right thing to do even for those athletes, but it has caused kind of this thought, if you will, that we need an image in order to know what to do. All right. And that couldn't be further from the truth. Okay. Sometimes an image actually brings in more questions than answers. And we're going to dive into some of why that is. All right. But many guidelines, whether that be orthopedic guidelines, family practice guidelines, actually suggest, that we should avoid advanced images like MRIs in the first 4 to 6 weeks after of a complaint, because they can often recover on their own. All right. There are certain presentations. I want to make sure I say that there are very certain presentations that need an image. All right. And a medical provider should help drive you down that pathway. All right. But I'd like to talk about a couple of things that should be considered. All right. When we get an image, or if we want one, or someone is ordered. All right. One is false positives. All right. So this is a finding that is actually not the reason for the problem. Okay. So another way to look at it, there is a high percent of our population that has abnormalities on their imaging, all right, but they do not have any pain or impairment. Okay, so that's a normal person. I don't have any pain, I have no problems, I function, I do what I want. But if I were to get an MRI, they would find a litany of abnormalities in my joints. Okay, that's a very normal thing. So why is that a problem? Well, the MRI, for instance, is very sensitive. It means it finds everything, all right? But it is not very specific, meaning it can't rule out what is or what is not the cause of the pain. So if we know they're present in normal people, and then somebody has an injury and we right away we get an MRI on it, and we hadn't evaluated how the problem behaves with movement, or if we've given them an opportunity to heal within that healing phase I talked about earlier, all right, we're going to then make assumptions based on what that MRI looks like. Has to be the reason why they hurt. Okay, and that can then be it could lead you down a treatment pathway that is not the right treatment for your problem. All right, because we're now depending on the MRI or the X-ray to tell us what we should do. All right, so just some kind of things to think about. They've looked at take the average person over the age of 45, half of the people walking around the planet without shoulder pain have a rotator cuff tear. All right. So if you're middle age or older and your shoulder starts bugging you a little bit and you've done anything from an athletic perspective in your lifetime, there's a good chance you have some level of tearing in your rotator cuff. But have we given it a chance to get better, and do we need to then act on that in the MRI? That's the question we should ask. Okay. Same goes for our knee. The meniscus, some studies have shown up to 62% of people have at least one meniscus tear. All right, there's two meniscus in each knee. All right, 36% have two. All right, these are people with no knee pain. All right, no impairments, no stiffness. So imagine if the first thing we do when someone's knee hurts is we do an MRI, we're going to find a bunch of tears. All right, and if we act on that, all right, just as they looked at individuals who had a meniscal surgery. All right, they had a 3-fold increase in the likelihood that they'll need a total knee replacement at some point. Okay, so we've got to be careful when we act on things that may or may not be the source of our symptoms. Arthritis may be the highest percentage. All right, in the majority of individuals, even in our 30s, we start demonstrating arthritic changes in our joints just under X-ray. All right, and then that just increases with every decade of life. All right, whereas once you're over the age of 60, it's almost 100% chance you're going to have arthritic changes. All right, so we really need to be considering whether or not that's what we should be acting on, or how we should be, if we should use imaging as the sole reason we evaluate somebody. All right. So a couple of interesting study. For those of you who may not be aware of Dr. James Andrews, he is like the orthopedic for the stars, if you will. Has a practice in Alabama, but is used by many professional athletes and college athletes. And he actually did a study, it's published in the New York Times, where he was trying to make this point that we overutilize MRI, and he took 31 pitchers and that were in Major League Baseball, and 90% of them had abnormal cartilage, and 87% had some type of abnormality in their rotator cuff. These are pitchers that are throwing the baseball faster than anybody on the planet. All right. And he did a follow-up study on those same people, and none of them ever ended up on the disabled list for an injury on their shoulder. Right, so just kind of food for thought there. Getting out what I was talking about earlier, if we research ourselves, I have shoulder pain or I have this, we need to be aware of what the source might be. I've touched on this in previous webinars, so I won't belabor the point, but there's a high percentage of, which you see the numbers here on the body, of local problems in our shoulder or elbow or our knee or our hip that are actually the sources in the spine. Okay, so finding the right source that we can then apply the treatment to is very important. All right. Speaking of pain relief and treatment, ice and heat. There's some debate out there on this. Ice and heat should be considered pain relieving methods. Okay. They tell the nerves in the area that they're hot or cold. And pain travels on the same nerve pathway as temperature. So if you tell it it's cold, the brain doesn't register the same amount of pain. If you tell it it's warm, same thing. Okay. That's how Bengay, icy hot, biofreeze. That's how those it's all chemistry. They do nothing for the phases of healing. So applying those things do not help you heal. All right. They just make your nerves think something else is going on, so they register less pain. Nothing against that, but just be aware of that's what they're doing. Okay. Should we use ice or heat? History, a lot of conventional wisdom says ice in the first 48, 72 hours. All right. But I've actually seen a lot recently that there's been some debate over icing reduces blood flow. And we actually want to increase blood flow when we've had an injury, because that's how the body gets cells to the area to heal it. All right. So if you need pain relief through ice or heat, feel free, but just be aware that one isn't necessarily preferential over another. Okay. All right. Inflammation. All right. We're going to dive into this real quick. All right. I mentioned earlier, this is a very important building block of the healing process. All right. It's necessary. It's gotten a terrible rap in our society. If we didn't have inflammation, quite frankly, we couldn't heal. We would all be a mess. All right. So now it is supposed to go away. All right. Within a matter of a few days or up to 2 weeks, depending on the severity of the injury. It becomes a problem when it doesn't go away. All right. And if it doesn't go away, it needs to be treated. All right. Well, why doesn't it go away? Well, in some cases, it's because the inflammation is the problem. All right. And then it needs to be treated with an injection or medicine. Okay. Other times it doesn't go away because the problem's not going away. So the body keeps the area inflamed, attempting to heal it. All right. So that is why often injections or medications fail. That's why if you hear your friends or yourselves say, well, I had a knee injection and it worked great, never had the pain again. And then you talk to somebody else like, yeah, it didn't do anything for me. That's because one person probably had an inflammatory knee. All right. Medicine took care of it. The other person had what we'd call like a mechanical problem, where the treatment wasn't appropriate for that because it wasn't inflamed. All right. So inflammation, very appropriate in the first few days after an injury, but it should go away. Okay. And often there's a source, all right, to the inflammation that needs to be addressed. All right. So that is the kind of the various topics. I know we kind of flew through a couple of those. I want to leave a couple minutes at the end here. So I don't know if I can kind of scan through the different topics, but Nick, is there any questions in the chat?
No, not currently. We don't have any questions.
Okay. Well, if anybody has, I'll kind of move to the, if you've been on our webinars in the past, that IMC has a variety of ways that we can, help you either with information or with treatment. We have a self-care web application. All right, that you can do self-assessment or even preventative movement tools that you can access. We also have a virtual care network that we can see you through telehealth. If you have these problems, you feel like you just need more questions answered. Apologize for some of the font got changed here. But if you do have a current problem, you're trying to self-treat, or now you're afraid to look at the internet for ideas, lean into some of the benefits you have. And I think speaking to a professional can be of extreme value. All right, well, I can hang out here for a couple more minutes.
Yeah, and there are a couple questions that just came in, actually. So the first one was, do statins cause muscle fatigue or pain or affect bone health?
Great question. As a physical therapist, we have a minimal amount of kind of training in pharmacology, enough to be dangerous at times. But I would say, yes, there are reported side effects of general muscle aches and fatigue. Has to do with like an enzyme that sometimes gets depleted if you take a statin, if you will. In 20 years of practice, I've had one individual, though, where that ended up being the root cause of their issue. All right. And so, and we evaluated his concerns, found that they weren't mechanical or musculoskeletal in nature, and he had a suspicion. So he talked to his doctor about some labs and things of that nature. So if you have those questions, or you've recently gone on a statin and then noticed kind of muscle aches and fatigue and some other types of things like that, then that's a great conversation to have with your primary care provider, because there are things that they can do to offset that.
Cool. And then the next question is, what about taping?
So if you're referring to like what they call like rock tape, or you see these like physio tape, which is like kind of elastic like tape, you see people who have an injury and they're trying to use that. I think that's probably what you're referring to. If you're referring to like taping an ankle for support, that absolutely has value if someone has a recent ankle sprain or something like that. As far as the other tape, it has actually been shown to be kind of in that compression bracing category, where it's more biofeedback. So it might deliver a message to your brain to move a little differently, or you feel a tug, so it limits your mobility, but it doesn't actually result in any biological like healing properties or anything like that. Okay, so it's an application that, like I said, is used for kind of biofeedback in people who might be struggling with something. And athletes will try anything if they're struggling with something to stay on the field or stay in their sport. And so that, fortunately or unfortunately, becomes a lot of what treatment gets modeled after. So hopefully that answers that.
Cool. And then the next question is, I stretch before weightlifting. Can you give me a few examples of the type of stretching I should be doing? Unless I misunderstood, I feel like I'm doing stagnant stretches where I hold for 10 seconds. So I think in general, the question would just be asking about examples of non-static stretching for weightlifting.
Yeah, so some of it can be, you could do some like body weight movement, like whether that be like going from standing to like a walkout to a plank and then coming back up. You can do what people call like the world's greatest stretch, where you kind of do a lunge and then put one hand on the ground and rotate. So kind of moving through your available range of motion versus taking something to its limit and holding it there. All right. Think like jumping jacks or like arm swings. Okay. Rotating your arms forward, backwards, across your body, but keeping the structures in motion. All right, those are some examples. And then the other piece would be, if you're going to weightlift, you might start. That's also where you might start with like a lighter set, or you just do body weight for the first set if you're going to do some squats. So maybe do some body weight squats, and then you go ahead and move into the weighted stuff.
Cool. And then we've got one more question, which is thoughts on stem cell injections and regenerative treatments.
Yeah, kind of a. So I'll start by just saying regenerative treatment, stem cells, plasma-rich protein, and all these things, they're experimental. They are not FDA approved at this point. That doesn't mean that they don't work in some people. I'm not saying that, but the FDA has not deemed them safe in all presentations. All right. Not to be controversial here, but they're also backed by a lot of private equity investment money. So there was a big push for these types of treatments, and I think they probably do have viability in very specific presentations. Right? But where sometimes these treatments then go kind of off the tracks is they try to apply it to a large swath of the population, rather than identifying how do we determine who should get that stem cell, right? Or who should get plasma-rich protein. And they make it anybody who is suffering from knee pain will do great with this. And that's where then you look at the studies, and the studies then don't really support it, right? And then if you look at this, some studies support it greatly, but then you look at who funded the studies. I got to be careful here, get my soapbox, but like the way that the literature is now, I think, published, and some of the studies, you have self-funded studies then are then advocating for their own treatment. And so we do truly need some like neutral, independent studies that try to hone in on who should get that treatment. All right. When we look at our internal data, so many problems are mechanical in nature. There's actually only probably about a 5 to 10% of the population who has a problem that's not that can't be changed with movement-based care, and those are often surgical candidates or injection candidates, and that's the swath of people that probably need to try those types of treatments. All right, so if you want to try it, I think I do a lot of research. I talk to your doctor about it, but they are not FDA approved in most circumstances yet.
Cool. I think that was it as far as the questions we have.
Great. Yeah, well, thank you, everybody, for taking some time out of your day to take that. And we'll be back with another topic in a couple months. So everybody, enjoy. Reach out if you have any questions.